Hello and welcome to our fourth episode of Practice Pearls podcast, an educational podcast about menopause for clinicians in primary care and OBGYN. I'm Amanda Clark, urogynecologist and menopause physician.
And I'm Kim Vesco, an obstetrician gynecologist.
And I'm Tovi Anderson, a family medicine physician.
Today we'll start discussion of specific case scenarios that you may see in practice, women with menopausal symptoms, but contraindications to hormone therapy. Our first case scenario is Mrs. Jones. She's a 54-year-old woman who comes in to discuss the return of hot flashes since she was recently diagnosed with breast cancer and had to stop hormone therapy. She has a history of depression and is reporting some recurrent symptoms.
Our second case is Miss Smith, a 53-year-old woman who recently had a deep venous thrombosis after air travel. Her only risk factor for DVT is obesity, with a BMI of 30. A workup for underlying coagulopathy was negative. Her last menstrual period occurred 14 months ago, and she's having bothersome hot flashes at night, which are disturbing her sleep.
Both of these cases represent situations in which estrogen therapy is contraindicated, yet patients have impairment of their quality of life due to menopausal symptoms.
Fortunately, there are non-hormone therapy treatment options for which we have good evidence. These options are also great for women who can take estrogen therapy but prefer to avoid it.
Before starting prescription therapies, I always start with lifestyle modifications. Since hot flashes can come on at any time, clothing choices can be important. Wearing things that breathe well, like light cotton or natural fiber materials, and dressing in layers can be helpful. Also having things on hand to relieve symptoms, such as a handheld fan or electric fan, or a container of cold water.
And for nighttime, wearing light clothing, keeping the temperature cool, and using a fan could be helpful. Women might even want to consider putting a cold pack under their pillow or turning the pillow over to the other side when they feel warm.
These days, exercise seems to come up as a good therapy for everything. But while aerobic exercise and yoga may have benefits for midlife and postmenopausal women for many, many reasons, clinical trials have not shown that exercise and yoga reduce the frequency of vasomotor symptoms.
While avoidance of triggers has not been tested in trials, there is some evidence from cohort studies. An association was found between alcohol use and vasomotor symptoms in an Australian longitudinal study of midlife women. Other potential triggers whose effects have not yet been tested in clinical trials are spicy foods and hot foods and beverages.
For women with overweight or obesity, several trials have shown that weight loss can reduce, and in some women, even eliminate vasomotor symptoms. In the Women's Health Initiative's dietary modification trial that included over 17,000 participants, women who were randomized to the intervention group were more likely than those in the control group to lose weight and to have their vasomotor symptoms eliminated at 1 year.
And in another randomized trial called the Women's Healthy Eating and Living Study, which was a dietary intervention trial for women with breast cancer, women who lost at least 10% of their pre-diagnosis weight had a 28% reduction in moderate to severe hot flashes.
And when lifestyle modification and avoidance of triggers is not effective enough, there are several effective medications for our patients to consider. Let's begin with prescription alternatives to hormone therapy for hot flashes.
Several categories of medicines have been shown to be effective for hot flashes in randomized trials. These include antidepressants, the gabapentinoids, and clonidine. Let's talk first about the antidepressant category of medications.
The only prescription therapy that is approved by the FDA for the management of menopausal symptoms, besides estrogen, is paroxetine. But randomized trials have shown that other selective serotonin or norepinephrine reuptake inhibitors, which we refer to as SSRIs and SNRIs, are effective as well.
The tested dose for paroxetine is low, 7.5 milligrams per day, and the onset of action is within 2 weeks. For women who have both depression and hot flashes, an SSRI or SNRI may be a good first choice. Potential side effects include nausea and dizziness, which usually resolve within 1 to 2 weeks.
Gabapentin and pregabalin are anti-seizure drugs that also show evidence in relieving hot flashes. The minimum effective dose for gabapentin is 900 milligrams per day in 3 divided doses. For pregabalin, it's 75 milligrams twice daily. Common side effects at these dosages include dizziness, unsteadiness, and drowsiness in the first week that most often resolves to baseline after 4 weeks.
The side effect of drowsiness can be a benefit for women with both night sweats and disrupted sleep. Both gabapentin and pregabalin can be titrated to higher doses to further reduce hot flashes, but side effects can increase as the dose increase, and this limits how high you can push it. Also, dosages must be adjusted when there's renal impairment.
The adverse effect profiles of these agents are the same whether they are used for hot flashes or for the original indication. Of note, both antidepressants and gabapentinoids have a black box warning for uncommon suicidal thoughts and behaviors.
Further, for breast cancer patients on tamoxifen, paroxetine and fluoxetine interfere with tamoxifen metabolism and should be avoided, although venlafaxine and citalopram may be used safely.
A third agent is clonidine. Clonidine is an antihypertensive agent that is an alpha-2 adrenergic agonist that relieves hot flashes better than placebo, but not as well as the antidepressants and gabapentin. The side effects of clonidine include hypotension while taking the drug and then potentially rebound hypertension when the drug is stopped.
So how do I choose between these agents? These two case presentations provide clues to guide us. Ms. Jones, our patient with breast cancer, reports depressive symptoms, so I would start with the antidepressant that worked best for her in the past. She says she has successfully used paroxetine in the past and that tamoxifen is not part of her current cancer treatment plan. I'd start her on the low dose for treating hot flashes, 7.5 milligrams daily, and then titrate up to 20 milligrams daily as needed to manage her depression symptoms. I'll warn her about the need to change agents if tamoxifen is needed.
For Ms. Smith, with a history of DVT, her most bothersome symptoms occur at night and interfere with sleep. I would start her on gabapentin, and I like to start slowly with this medication. I'd give her 300 milligrams on the first night and aim to increase the dose to 300 milligrams 3 times a day as quickly as side effects will allow. If needed, one can titrate the dose even higher, up to 2,400 milligrams in a day, but side effects are more frequent as the dose increases.
A lot of patients want natural remedies like soy and black cohosh, and supplementing the diet with soy foods is a popular approach for helping with menopausal symptoms. So let's discuss the evidence for the use of soy and herbal remedies for vasomotor symptoms.
Soy contains several isoflavones, a class of phytochemicals that bind to estrogen receptors. Despite many studies, soy supplements have shown no benefit over placebo.
That said, there's one metabolite of soy that you should keep an eye on, called S-equol. One of the common soy isoflavones is metabolized to S-equol in the gut, but only 1/3 of North American women can make this conversion, in contrast to 50 to 60% of Asian women. This difference is proposed as a reason why hot flashes are less prevalent in Asian compared to Western women. S-equol has now been produced as a supplement, and early studies do show promise.
Continuing our discussion of natural remedies, a lot of women try black cohosh. I think it's because it's readily available in grocery stores. Black cohosh has been studied in many trials and has not been shown to be effective for menopausal symptoms. There are also some case reports of liver toxicity with its use, so probably best to avoid this one.
Now we come to the list of things that have been studied and have been proven not to work.
Crinum, derived from the amaryllis plant, Dioscorea from wild yam, dong quai, also known as Angelica sinensis, and evening primrose oil.
And are you ready for this long list? Flaxseed, ginseng, hops, omega-3 fatty acids, combined botanical remedies, and vitamins. And there's some things that I've never even heard of. Maca, which is a root grown in the Andes, pine bark, pollen extract, and Siberian rhubarb.
That is a long list of things that don't work. Clearly, there's a lot of motivation out there to try to identify many ways to help women relieve their menopause symptoms. The key resource I use for this information is the NAM's position statement on non-hormone remedies, which is posted on our podcast homepage and on the NAM's website, menopause.org.
So just to recap, research has not yet identified herbal remedies that are clearly effective, although new research may provide insight into the potential benefits of the soy metabolite S-equol.
So we've covered lifestyle modification and prescription and herbal products. What are other alternative therapies that we might consider?
Cognitive behavioral therapy has been studied in randomized placebo-controlled trials and shown to reduce bother but not the frequency of hot flashes. In these studies, the approach was delivered in a group setting or in a 4-week self-guided program.
Hypnosis has shown benefit in 2 small randomized controlled trials. Mindfulness-based stress reduction has limited supporting evidence, with 1 small trial showing improvement in hot flash intensity that was not statistically significant.
So let's review some key points from today. The prescription options that have shown effectiveness for treating hot flashes are the SSRI and SNRI antidepressants, gabapentin and pregabalin, and clonidine.
In the category of herbal remedies and supplements, there's good evidence to show that most do not work and that a popular choice, black cohosh, may cause harm.
A potential exception is the S-equal derivative of soy, a supplement that has shown promise in early studies.
The treatment we've discussed so far are those studied for treatment of hot flashes and night sweats.
For our 2 cases today, we haven't yet discussed vulvovaginal and urinary symptoms. Both of these patients are at risk of having these symptoms.
If Miss Jones is given an aromatase inhibitor for breast cancer treatment, that will suppress her endogenous estrogen levels to near 0 and really increase her risk of vulvovaginal symptoms.
We also want to let you know that there is a new name for symptoms related to vulvovaginal atrophy. The new term is the genitourinary syndrome of menopause, or GSM for short.
Vulvovaginal symptoms of GSM include dryness, irritation, and painful sex. Urinary symptoms include frequency, urgency, and incontinence.
These vulvovaginal and urinary symptoms are very common, occurring in half or more of postmenopausal women. In contrast to hot flashes, which tend to diminish as time passes after menopause, vulvovaginal and urinary symptoms tend to worsen as the years pass after menopause.
And although these genitourinary symptoms are very common, women don't often tell us about them. Many women believe that these symptoms are normal consequences of aging, and they don't know that we have effective treatments. Some women may be embarrassed to discuss these symptoms with us.
So these become important screening questions. We have to ask them because we know that women won't report these symptoms.
Recurrent urinary tract infections in menopausal women are another component of GSM. We know that menopause is a factor because local vaginal estrogen therapy is highly effective in preventing recurrent UTIs.
The non-hormone therapies we've discussed in this episode don't treat GSM or a recurrent UTI. In our next episode, we'll delve further into the genitourinary syndrome of menopause and its treatment options.
Join us next time for a discussion of GSM.
This is Amanda Clark
and Kim Vesco
and Tovi Anderson. Thank you for listening to Practice Pearl's podcast, Menopause.
All cases appearing in this work were developed to highlight common clinical scenarios. Any resemblance to real persons, living or dead, is purely coincidental.